thanks. It was really good of you to come. Hopefully you've all been through the online accreditation system, and therefore you've done the theory and the topography sections already. And today's webinar is really very much focused around how to fit OrthoK. So what you do with those patients that are in front of you and how you actually deal with those patients. Normally, I would get you to ask your questions as you go, and you're very welcome to temporarily turn your microphone off and just chip in with questions. On the other hand, if you'd rather pop them into the chat box, do, but it probably is the case that I'll only be able to look at those towards the end, otherwise I'll get lost during the presentation. Another bit of the usual housekeeping to let you know, as well as recording the presentation today, you'll also get a copy of the slides. You get that in a folder which is called Further Reading, which you'll get a link to when you complete the last test of the accreditation system. And it will be these slides and actually the slides from the previous presentations, as well as a few documents that we refer to throughout this presentation today. So it's a useful resource to go back to. You do need to be signed into the accreditation system to be able to access that. But let me know if you have any problems with that at any point. So we're going to move on to our first slide. So some of you may be working in practices that have already fitted OrthoK. Some of you, it might be brand new to you. What we've learned over the last 15 years or so, probably coming up to 17, 18 years now, is that the practices that do really well with OrthoK are not really doing anything different clinically than the ones that do less well. They're just really good at selecting patients. So they're really good at knowing who it's likely to be successful for and who it might be less likely to be successful for. So these next few slides aim to give you some pointers so that you can choose the right patients and therefore... we're still having an echo on me. If you give me just a second, I'm going to go and get a headset and just see if that improves the echo, because echo is horrible. So I'll be back in one moment. This will be a really interesting part of the recording, seeing me leave through the door. So I have now stolen my daughter's gaming headset. So if anybody could let me know in the chat whether that's improved things or not.
Can you hear us?
I can now hear you.
We weren't getting an echo anyway.
Ah.
You were coming through loud and clear.
So maybe it is that. Let me see if I can boot this person out. It's always good fun, this part. So, right, I'm going to throw out 20 Matilda and see what happens. Right, I'm going to carry on. Let's hope that we've still got everybody. So, patient selection. The first and most important thing to think about is refractive error. So do we have patients that fit within the range? And the range is -1 to -550. Below -1, the patient's really not likely to get as much benefit from it as they should do. And the evidence for OrthoK really suggests that it's consistently effective up to -550. You will see case reports of patients who've been fitted with prescriptions that are higher than this. But the overall consensus is that the data supports up to -550, and that beyond that, your success rates drop off really quite dramatically. And there isn't great data to suggest that those higher corrections are safe either, not because we're necessarily saying that they're unsafe, but just because we don't have the weight of data behind it to say that it is. Your astigmatism at the moment is different for your with the rule sills and for your against the rule sills. So your with the rule sills are your horizontal minus sills, and they can be corrected well up to around -250. Your against the rule sills, however, so that's your vertical minus sills, generally do less well with the traditional ortho-K design. So they can really be corrected up to only -1. What we are able to say is that later in the year, we'll be launching a new toric design, and that toric design will actually give us 250 sills around the clock. It's a different level of toricity for different patients in the periphery. So if you go back to the theory slides, you'll remember that the toricity is actually only worked into the periphery, and that's to flatten that central zone and make it spherical. And by customizing that peripheral zone even more, we'll be able to offer you 250 sills around the clock. So you will automatically join our update list, and we'll send out that information when we have it. But for the moment, we're sticking with -250 for with the rule sills and up to -1 for against the rule sills. Your with the rule and your against the rule can be a plus or minus 20. Anything in between that, those oblique sills, you may need to really decide whether that patient is going to tolerate having that sill as a residual, because it's unlikely to go anywhere. When you're doing your history and symptoms, you need to think about your patient's previous corneal health. You need to have a think about their corneal irregularities if they have any. So in ortho-K, we always think of the topography having 3 functions. The first one is to screen for a normal eye. The second one is for designing the lenses, and the third one is for follow-up. So if we think about the screening here, if you have a patient who already knows they have an irregularity, then you can make sure that you exclude those patients very early on. But it may be that your topography that you take for ortho-K picks up some of these irregularities. They could include keratoconus. Now, ortho-K on a keratoconus patient sounds like a lovely idea, because you're going to smooth out that keratoconus and make that cornea nice and even and regular and get rid of all the aberrations that go along with it. But unfortunately, our keratoconus patients have a cornea which is thinning and progressively thinning for many of them. And ortho-K thins the central cornea slightly, central epithelium. And so adding that thinning onto an already diseased thinning eye is unwise. It's also not a normal shape to start with. So we have the cone shape rather than that lovely normal prolate shape that we would have for a normal cornea. And therefore, again, it's likely to be unpredictable. So we're going to screen out our patients with keratoconus. And as soon as you start doing more topography, you start picking up patients who may have subclinical keratoconus that you hadn't been aware of before. So it is worth having giving some thought to how you would talk to those patients for whom maybe their keratoconus is never likely to progress into a condition that would need any treatment, particularly if they're older, but also that you are going to exclude them from ortho-K. So scarring. If you're fitting a regular contact lens, so maybe just a daily disposable or monthly disposable, you're really only going to think about scarring if it affects the vision, if it's over the pupil, or if it's causing distortion to the cornea that's affecting the vision. In ortho-K, we have to also think about how scarring might affect the fit, because we need that really lovely close alignment fit in the alignment zone to allow the forces to work properly to change the shape of that cornea. So if you had scarring in the mid-periphery that led to a raised area or a dip, then you may find that actually that lens doesn't fit close enough, and therefore the forces don't work equally in all directions, and therefore we get stuck and aren't able to create the correction. If the other thing to remember, of course, is that scarred tissue doesn't have the nice neat layers of the cornea that you would have in a normal cornea. It's kind of knitted together, and again, that's going to make it more difficult to achieve the effect you want. If you have a peripheral ulcer scar right out in the periphery, out of the area that the lens is fitting in, then you probably don't need to worry about that at all. However, if you have a patient that has 3 peripheral ulcer scars in one eye and 2 in the other eye, you need to be asking yourself why they keep getting peripheral ulcer scars, and really consider whether they're a good patient for overnight wear. Previous refractive surgery. Now, again, it sounds attractive to the patient because maybe they had refractive surgery, maybe they even had a retreatment, and they've still become myopic. And it sounds lovely to be able to do ortho-K and still be lens free in the day. But if they had a minus correction in the past, they've already got an oblate shaped eye, so an eye that is flatter in the centre and steeper in the periphery. And that's the shape that we're aiming to achieve with ortho-K. So you're unlikely to be able to create the shape that you need to correct their refractive error. So clinical dry eye. We talked about the benefits in the online stuff about the benefits for patients who have that kind of marginal dry eye. So the dry eye that's related to contact lens wear, so contact lens associated dry eye. They do really well in ortho-K because their contact lens wear is only at night. And it's in a nice closed, moist eye that's sealed and not attacked by the kind of environmental issues that you have in daytime wear. If we separate that from my definition of clinical dry eye, and my definition here would be that the patient has signs or symptoms of dry eye when they're not wearing contact lenses, those patients are likely to potentially have staining, which would be an entry point for infection. And secondly, they don't have a good tear film, and we know that tear film forces are responsible for the change in the corneal shape, and therefore they're not likely to get the shape that we need. Some of our dry eye patients are dry eye patients because they have blepharitis or meibomian gland dysfunction, etc. And if you are able to get that patient with good treatment to no longer have those signs and therefore no longer be a dry eye patient, you could proceed with ortho-K. However, you've got to get the patient to accept that it's a chronic condition, and therefore you need to make sure that the patient can actually what's the word I'm looking for? That they're going to commit to making sure that they actually carry on with that treatment. And it's not the case that all patients will do that. So I think dry eye patients are best avoided, but if you have a really highly motivated patient, then you could actually consider continuing with ortho-K once they've had the treatment. Degenerative corneal diseases, that's probably fairly self-explanatory, as is active anterior segment disease. Some of the trickier ones that we come across are the ones where a patient has had a problem in the past. So, for example, scleritis or iritis. And I get the question occasionally, what should I do about that patient? Could they be fitted with ortho-K? Well, there's no reason to think that ortho-K would make those conditions come back. But what we do need to do is make sure that the patient would be able to separate the symptoms of a corneal problem related to the contact lens from a recurrence of their previous condition. I think I'm kind of slightly scarred on this one from a patient that I saw, well, actually my first patient in my pre-reg year, who'd once had iritis, and her GP had intermittently given her steroid drops for about 15 years, and she developed hugely dense cataracts at the age of 30 because the GP just kept giving her these for any minor irritation. And obviously what we don't want is a patient with a corneal infection going off to their GP and being given steroids instead of getting correct treatment. I hope that you recognise this patient when I talk about this patient. This is the patient who doesn't have dry eye symptoms. They may not even really show any particular signs other than maybe their kind of slightly red lids, slightly inflamed lids, and just generally thick, yucky tears. These patients aren't symptomatic, so it's very hard to get them to do anything about this, but their eyes just aren't quite 100%, and they seem to also not do so well. When you get onto your general health history, it's the only absolute exclusion that I'm going to offer you is patients with diabetes. And this is because they have reduced corneal sensitivity and poorer corneal healing. And this means that they're likely to present later if they have a problem and also be more difficult to treat. So just from a safety point of view, it's best not to fit patients who have diabetes. But everything else, it's about thinking about what effect that either that medical condition or that medication has on the patient's eyes. So does their medical condition cause their prescription to fluctuate? So if their prescription is fluctuating down to medication or a general health condition, in ortho-K, it's going to be incredibly difficult, if not impossible, to try to pull apart what might be down to the underlying condition and what might be down to ortho-K, and make changes to the lenses to compensate from that, because you can't do that thing that you would do in regular contact lens wear, where you just do a basic spectacle refraction and establish what the refraction is at that point. So for that reason, those patients are going to be very difficult to manage. And then also you've got the medical conditions and also the medications that could cause dry eye. And the reason that I've pulled out Roaccutane here specifically is because it's an acne medication, and therefore may be something that's prescribed to the older end of our myopia management group. It's a very effective acne medication, but it's really kept for the more serious cases because it has a number of side effects. One of which is actually that all the other mucous membranes dry out hugely, so that it's eyes, nose, mouth, etc. And you'll see as we go through this presentation that a lot of this presentation is don't do all the dumb things that I've done in the past. And one of them is a patient in their late teens coming in with two bright red, angry eyes, really, really upset looking. And in my head, I'm going through, have they got an infection? Have they got inflammation and allergy? Are they allergic to the solutions? Have they put peroxide in their eye instead of their regular solution? And I went through all of those regular red eye kind of things before we eventually said, have you started any new medication? And the patient was just a couple of weeks into a course of Roaccutane. It's also worth bearing in mind that the dryness can actually persist long after the Roaccutane is finished, so sometimes for months, but sometimes even permanently. So if you do see patients of that age group with very dry eyes, that might be one of the reasons that you see that. So from a lifestyle point of view, our best patients are patients that don't want to wear lenses in the day, and that can be adults who are seeking ortho-K for vision correction, but just also as a benefit for those doing myopia management. They sleep at least 6 hours at night. Now, that is most critical in that first couple of weeks when we're trying to establish success. By the time we get to beyond that, the lenses are really acting very much as a retainer. So they're not creating such active forces underneath it, and therefore the 6 hours becomes less critical. But in that first few weeks where we're trying to work out if it's going to be successful or not, we want our patients to try to commit to that 6 hours. Now, our younger patients are likely, sort of 8 to 12-year-olds are likely to be getting that amount of sleep really easily. Our teenagers would love to sleep for much longer than that, but maybe they're night owls, and maybe they're going to bed early in the morning and then having to get up to go to school or college. And so it's important to have this discussion with them. And adults, many of them are getting that and many of them are not. So again, have that discussion with them and try to get them to commit to that just for that first couple of weeks. Now, shift workers can be challenging to fit, and that's not really because, well, absolutely not because there's any difference in daytime sleep and nighttime sleep in terms of how effective the lenses are. It's more about actually managing those patterns. So, for example, if a patient works a night shift, they might not wake up for that night shift until 7 or 8 in the evening. And if we want to see them after their first sleep in the lenses, we're unlikely to be open to see them for that. So we may want to see if they have some annual leave that they could use, or that we're able to see them when they're on a daytime shift pattern if they fluctuate between shifts. And then the other problem is that when patients change shift patterns, sometimes they don't try to sleep more, they actually just extend that awake period for longer for that shift change, and that then could mean that they get some tail off within their correction. If that is the case, then there can be ways around shift patterns. You can do some top-up daytime wear. You'll remember from the theory presentations that the lens is flat in the center to the extent of the patient's prescription. So therefore there's a tear lens behind that lens, which will always be correcting the prescription, so they can always see with the lenses in. So top-up daytime wear will give them good vision. The problem with daytime wear is that you get all the issues of movement and lid hitch. So you get lid hitch and then movement after blink and gravity causing that lens to drop, so the lens becomes mobile. And that can blur your topography pattern quite significantly. So it makes it much harder for you and us at number 7 to judge the position of that lens. And in its worst case scenario, if you have a patient who's worn their lenses for a number of hours in the daytime with significant lid hitch, it can actually create a double ring. and it can kind of create a little bed that the lens then goes and sits in overnight high on the next sleeping cycle. So we avoid daytime wear if we can, but it is there as a good backup if we need it. And then no pajama folders. So I think you will recognise these kind of patients. These are those patients who have razor sharp creases in their pajamas, very shiny shoes, but optically they're the ones that will argue about the axis on an 025 sill. They're the ones that collect their new specs and they cover one eye and then they cover the other eye. And then my favourite kind of patients are the ones that start doing weird head movements, trying to find a blurry bit of the specs. They're the ones with the records that when they were paper records were a big stack of paper records for all the non-tolls that they came back for. And they're super fussy. And we have taught them to be super fussy because we have taught them that nothing is acceptable except the bottom line with both eyes. We keep making them see smaller and smaller bottom lines with our computerized test charts. And we've kind of distorted their reality of what good vision is because we've made them believe that only perfect vision is good vision. You'll also recognise this characteristic about them, which is it's all those engineers, maths teachers, physics teachers, accountants, etc. So it's that super high demanding patient. And unfortunately, they're pretty much all myopes. My parents conducted a fantastic genetic experiment by being, well, my mum is plus 650 and my dad is -7. So they conducted a genetic experiment by having 4 children, and we are all between about plano and about -1. So their experiment worked really well. But my dad, the myope, is that super fussy pajama folder. Refracting him is an absolute nightmare. Because partly he's actually a GP wearer, so he gets some spec blur, but he's so fussy. So it feels like take hours to refract my dad. Whereas my mum, with her plus 650, could wear any pair of specs from the last 30 years and she would be happy. And if she wasn't happy, she'd just find another pair and put them on top. So they fall very classically into those myope and hyperope stereotypes. Before I worked in Ortho-K, I worked in refractive surgery co-management, and that really taught me that it's very important to set expectations from the beginning, because the biggest cause of complaint in refractive surgery at the time was actually nothing to do with infection, inflammation, flap problems. It was all about a mismatch between the practitioner's expectations. So that's either the optometrist, but more importantly, the surgeon's expectations of success, and then the patient's idea of success. We're going back sort of 15, maybe 20 years here. And if you think about it back then, a lot of the people doing refractive surgery were experienced corneal surgeons, but they were used to doing corneal grafts on patients with very, very poor vision. And so if they did a corneal graft on a patient who had keratoconus, who had exhausted all the contact lens options, and they got that patient to see 612 unaided, then everybody was delighted, surgeon and patient. And some of them took that expectation through to refractive surgery and found that 6.9 was a good expectation for them to have because that meant the patient was comfortably driving. But most of the patients having refractive surgery had come from specs or contact lenses and were used to seeing 6.5, and therefore 6.9 was awful for them. And there was just this real mismatch about what was good and what was bad. Surgery techniques improved very rapidly, and it meant that we were able to offer patients much, much better vision outcomes, but we still needed to be careful to make sure that they knew that one eye might be a little bit better than the other. We weren't expecting a big difference between the two, but if they were going to do the covering one eye and then the other, then that they might notice that. So in Ortho-K, we want our patients to expect good vision all day. We don't want them to believe that there's a kind of Cinderella moment at 10 p.m. where they pop back to being -4. We always talk about regression in Ortho-K presentations, and you'll have heard me talk about that in one of the previous recorded videos. But I think that we massively overplay it. We talk about this shift as if it's common, and actually it's really uncommon for patients to notice a significant difference in the vision. It tends to be rare and therefore something that we need to do something about rather than something that we should assume is normal. But one eye might be a little bit better than the other, and actually it might vary day to day. It might be the right eye that's better today and the left eye that's better tomorrow. Another thing that I realised when doing Ortho-K is that the patients actually, they tell you if it's successful or not. And this is back to that refractive surgery idea of 6 happy. I would have these expectations quite rightly that the patient is going to see really, really well, because many patients see 6-5 right and left. So if I had a patient who saw 6-5 in one eye and 6-6 minus in the other eye, I was there trying to make that 6-6 minus eye better. And I was doing that even if the patient had come in telling me how brilliant it was, telling me that it was the best thing that had ever happened to them and how excited they were by it. And then I would send off the topography, and I would either be told that there wasn't any improvement that could be made with another lens, or another lens would come and it wouldn't improve it. And I'd kind of knocked that patient's idea that it was successful. So therefore, I think go with your patient's idea of success. And if they're happy and you're happy with the level of vision that they're getting for things like driving, etc., then I think you can leave well alone. The other thing to remember is that we're actually aiming at plus 050 for post-treatment refraction. And if you're checking a residual refraction with a trial frame and you're dropping lenses in and out, the patient may actually start to become alarmed, because they might think that that's a problem, that there's something that's not quite right about it. So it is good to tell them that there is likely to be lenses left in the end, and that doesn't mean that there's a problem. So who might want Ortho-K? If you're looking at adult patients, then actually you should be thinking about talking about it to all your soft lens wearers, because we know that soft lens wearers are generally happy. That's why they continue wearing them, but maybe they would be even happier if they were lens free. Some of them will take you up on it. Some of them will do that immediately, and some of them will think about it for 6 months or a year and maybe mention it at the next aftercare. But if you've never mentioned it to them, there's very little likelihood that they've heard about it elsewhere. So it's a good idea to sow that seed. An area that we found particular success with was dropouts. So your patients that either have already dropped out or are on the brink of dropping out of soft contact lenses, because they obviously wanted something from contact lenses which was likely to be being spectacle free, but they weren't able to continue. And we know from all the work that the soft lens manufacturers have done is that the reason that most patients drop out of soft contact lenses before presbyopia is actually down to comfort. Once you go beyond presbyopia, vision comes into it much more, but pre-presbyopia, it's about comfort, and they tend to describe that comfort as dryness. And we've already talked about the benefits for those sort of marginal dry eye patients. A lot of your kids, though, if they're going into it for myopia management, will be spectacle wearers, and there's no reason to give them a kind of trial by daily disposable to get them into Ortho-K. It's a different process, different handling, and it just puts a barrier in the way. So I would suggest going straight from specs into Ortho-K. And then the reason that we took it up in practice was because we were seeing patients who were being turned away for refractive surgery because their prescription was still changing, or because their corneas were too thin, and we were able to offer them an alternative when they were disappointed that they couldn't have refractive surgery. So to summarise, the patients we want are under minus 550. They're not obsessive about their vision. They have healthy eyes and they're generally healthy. Don't they sound like lovely patients? Statistically, there are loads of those patients out there. So that's either adults for vision correction or they're children. And honestly, I think there are fewer children than there are adults that are suitable. But you're always going to be in the best position by offering it to both groups, because statistically the peak of the distribution of prescription is still around that -3 that it's been for a very long time, and therefore there are lots of these patients. But the reality is maybe that some of us are not seeing those patients anymore. Maybe some of those patients are going for somewhere that is super convenient for them, or unfortunately cheaper, and therefore we'd like to attract those kind of patients back into the practice, and this is a really good way to do that. So you've already established that this patient is potentially suitable. If your front of house team haven't yet done our front of house webinar, then I'd really encourage you to get them to do that. They sign up to it on the website on the same page as the EyeDream accreditation. And it just helps them with screening some of the questions as well, and maybe booking you in the most suitable types of patients. So I would suggest that you send them a link to that or point them in the right direction. But hopefully they've done a bit of pre-screening, or you've talked to a patient in a previous appointment and you've got them booked in for this assessment appointment. And it's one of those weird contact lens appointments where you actually don't end up with any contact lenses to put in the eye at the end of it. So personally, I don't think it takes any longer than a regular contact lens assessment, because it's really mainly about capturing the data ready to go forward. When you do your initial assessment, you want to do a good history and symptoms. So you want to talk to them about general ocular health, etc., previous contact lens wear, any previous contact lens wear problems. But that's very much the same as you would be with a normal contact lens fitting. The difference is that you ideally are going to add in some questions about their sleeping habits. So you're going to be asking them about hours of sleep, sleep patterns, are they shift workers, etc. In an ideal world, you would also be asking them if they slept in any weird positions. But I haven't found a way of asking this without sounding like a scary stalker. So if you can manage that, then go ahead. What you're not looking for is, do they sleep with any excessive pressure on their eye? So it's absolutely fine to be a side sleeper, absolutely fine to be a back sleeper, even a front sleeper, as long as you're not putting excessive pressure on that eye. So it's the people that sleep on their hand, or sleep with a pillow wedged into their face, or sleep with a teddy bear in a child. And that's just because it really is going to cause you a problem with decentration of the lens. Because I can't find a way of asking it, often the time I find out is when I've said to a patient, unfortunately, we can't get this lens to center, and it's just, we've tried everything. And they say, is it because I sleep on my hand? And I say, well, yeah, probably. One other thing that you can ask, and particularly parents of younger children, is, do they sleep with their eyes open at all? Because that's going to help you if you come across any staining later, to explain that, etc. You're going to do a refraction. If it's not your own refraction, or so it's an external one or a colleague's refraction, just make sure you pop it up in a trial frame, record the visions with that, and also just check for things like balance lenses, sills that have been adapted for patients to get on with them better. So modified sills, both in terms of power and axes, because what we need when we do these calculations is we need to know that we've got the full prescription, and we need to know whether it matches with the corneal curvatures. So if we've got a patient with astigmatism, we want their cornea to have the same level of astigmatism, and so we need to know what the full prescription is. Now we're going to have a really good discussion about how the process works. I have put together a patient journey document, and it's one of the documents that you'll find in that folder. And it came about because I unfortunately had a patient who complained to my managing director that I had told her that Ortho-K was a cure for her myopia, and that she would never have to wear lenses after the first couple of weeks. And I know 100% that I didn't say that, but because I hadn't had anything that I could give her, maybe that's the impression that she took away. So by giving her this patient journey document, we would have been able to avoid that, and so therefore it exists for future patients. And it really just talks to them about how many appointments they're committing to, what the long-term costs are, what the immediate costs are, when the lenses will be replaced, and how often they'll need to come see us in the future. Because Ortho-K is not a huge commitment beyond the early stages, but it is worth them knowing exactly what they're committing to. So you'll find that document in that folder. You can do a full slit lamp and tear assessment, very much the same as you would do for any other contact lens, and you're going to do their topography. So some of you will be in practices where topography has been standard for a long time. For some of you, it might be new, or even you haven't yet started. Topography can be affected by any kind of contact lens wear. So any kind of contact lens wear can mold the cornea a little bit. In thin daily disposables, it's going to be really minimal. And you could probably just say to the patient, don't wear the lenses for the day of the appointment, and you're really not going to see any effect from that lens. And in fact, for something thin like One Day AccuView Moist, for most patients, you wouldn't notice it even if they just took it out immediately before the topography. But as a lens becomes stiffer, it's more likely to have an effect on the corneal topography. So any reusable soft lens, including the modern silicone hydrogels, I would say the patient needs to be out of those for a couple of days before they come into the appointment. If you have those patients who are still in those early generation silicone hydrogels, so the Night and Day or the Pure Vision, the ones that really sit up like a bowl on your finger, they can have quite a significant moulding effect. So you want those patients out of those lenses for a week before you take the maps, and that is something that will really improve your accuracy of your maps and therefore improve the accuracy of your custom-made lenses. If you look, you'll be able to find case records of patients who, back when we were fitting these lenses more for extended wear, wore an inside-out night and day for a week or so and actually lost about 2 diopters of their myopia, so a silicon hydrogel ortho-K effect, and they lost it because they wore the lens inside out. And when you put an inside out night and day in and put some fluorescein in, you actually see the ortho-K pattern, you see the creation of a reverse geometry ring, so you can see how it could happen. And in some ways, it's a shame that we haven't been able to manipulate that and make ortho-K potentially monthly disposable, but unfortunately, it's not predictable enough to do that. If you have a gas permeable wearer, this is again a point to learn from my stupidity. So I had a patient and I'd fitted her daughter with ortho-K, and her daughter absolutely loved it. So she decided that she wanted to start doing ortho-K. But up until that point, she was a very happy gas permeable wearer. That should have been my clue. And I should have said, if you're a happy gas permeable wearer, you'll never really be as happy with a vision with anything other than your gas permeables, because the reason you're still in your gas permeables after all these years is because you really like fantastic, perfect vision. But she was really keen, so we decided to go ahead and we decided to take her lenses out and let her cornea establish its natural shape. And working in refractive surgery, we used to be told that they should be out of their lenses for a month per decade of wear. So a 20-year RGP wearer should be out of their lenses for a couple of months before you even start trying to establish stability. And what you want is 2 consecutive maps, 2 weeks apart, that are exactly the same. So we took the patient out of the lenses, and she didn't have a pair of specs because she was your classic GP wearer. And so we fitted her with some soft lenses, which she didn't like the vision in. And then she liked the vision less and less and less over time because sills started to appear that hadn't been there before. And they fluctuated hugely. The axis swung 40 degrees. They went up and down in power. But at one point, they went over the 250 sill correction, which meant that she was out of range for ortho-K anyway. So this is probably 3-4 months down the line, at which point we had to exclude her from ortho-K and get her back into RGPs, which she'd lost tolerance for and actually didn't fit as well as they used to because of that corneal sill coming out. Because she'd been in hard lenses for long enough that the lenses were fitted best they could be, but the cornea had to have an element of fitting to the lenses. And so therefore she was needing to go into a toric lens, which would have cost her more, but which at that point I absolutely could not charge her for. And the worst bit of this story is that she lived about 4 doors down from my house. So I used to see her on days off when I was getting the shopping out of the car. She'd come up and say, oh, my left eye seems a bit worse today. And I'd have to repeatedly say, why don't you make an appointment and come into the practice? So my take-home lesson here is don't fit gas permeable wearers unless they were already going to drop out of gas permeable wear for another reason. And then in which case, manage them out of the gas permeables before you look at ortho-K. And my second take-home message is people that live on your street should probably see another optician. Pupil diameter. Now, you would imagine that pupil diameter is really, really important because for your adults, you would want your adult patients to have a pupil that is smaller than your treatment zone because that's going to minimize your glare and flare. And for children, for myopia management, you would want their treatment zone to be smaller than the pupil so as to include that peripheral plus and therefore get our myopia management effect. If we look at adults in the first place, we know from data that our colleagues in the Netherlands gave us that there is very poor correlation between pupil size and glare and flare symptoms. So we know that patients with small pupils may still experience glare and flare and that patients with large pupils may not. And so my approach to this is no longer measuring very carefully with a ruler and a Burton lamp or maybe my little circles on my specialist ophthalmoscope. What I tend to do is turn the lights off. And if I have a patient who has a very large pupil, you know, the kind of ones where the iris almost disappears, then I talk a lot more about glare and flare, particularly at this time of year, because there's so little daylight around. They're likely to be going into work in the dark, coming home from work in the dark. And what we tend to tell patients is that the treatment zone size actually gets larger over the first couple of weeks of wear, and it smooths out, so it becomes more regular, and therefore their glare and flare symptoms are going to be improved by that. And that goes along with the fact that their brain gets adaptation, so their brain gets better and better at switching off that glare and flare, and therefore their vision is likely to improve. If you have a real problem with glare and flare, you could always think about ceasing treatment at that point and picking it back up in May or June, because by the time the patient gets around to the autumn and winter again, they're usually well adapted and don't have that problem. For kids, we know that the bulk of the Ortho-K research has been done on lenses that have a 6mm treatment zone, and that those lenses have been shown to be effective. And we also know that actually any smaller treatment zone is really only offers us theoretical benefits. We don't know that that is going to give us a better Ortho-K effect. So at the moment, we still have just a standard treatment zone, although you may see in the future a smaller treatment zone offered if we find that the evidence begins to support that. But we do know that that 6mm treatment zone is very effective in pretty much all the published research that's out there. With your slit lamp, you're going to do exactly what you did for all your other contact lens patients. And if you do have any problems, treat before starting Ortho-K rather than try to do it alongside Ortho-K. So your lens order is your prescription, your corneal diameter, and your patient's topography, and it's all sent via our EyeDream software. So we talked about the fact that topography is going to create our empirical fit. And so what we do is we combine the topography with those other features within the EyeDream software. One of the documents that you're going to get in that folder is a very simple screenshotted pictures of the EyeDream software with ugly arrows added in paint to tell you what to do. So it's not pretty, but it does the job, and you'll be able to print that out, laminate it if you want to, keep it near your topographer so you know what the stages are. But I'll go through that very briefly now. So you take your topography in the topographer software, and then you export it out into the EyeDream software. If you're using a Keratron Scout or a Medmont, there's a button built into the topographer software that allows you to do a direct transfer into the EyeDream software. If you're using another topographer, then you have to export it out into a folder and then import it into the EyeDream software. So it's just another small step. Once you've done that, your patient's information will appear in the database. At this point, you have to go through an initial step, and that initial step is to click on this button here, which says Change Type. When you do that, a drop-down menu appears that gives you the options of Unknown, EyeDream, and EyeDream Monovision. You just select between EyeDream or EyeDream Monovision if that's what you're doing. You have to do this and to make sure that you're actually able to place an order, because if you leave it as unknown, then you actually are don't gain a tab on this top section here, and therefore you can't place an order. So once you've clicked and changed it to EyeDream, you'll see that this extra EyeDream tab appears on this top line, and that's the bit that allows you to order. It's probably the most common technical query that we get is, why haven't I got that final EyeDream tab? And it's just because people have forgotten this first step. It's frustrating because it doesn't appear to actually do anything, but it's an important one that you carry out. So once you've clicked on that, you can then click on OD, and that's for our right eye. And what you'll see is your patient's topography. But because we've moved it into the EyeDream software, we've lost an image of the eye if your topography software shows you the image of the eye. And the colours might be slightly different because it might have attributed a different colour to a different curvature, but the overall shape will be the same. And what you're looking at here is not a photograph of your topography, it's actually genuine topography data rebuilt into the software. So you can manipulate it between axial and tangential. You can look at your absolute maps, you can look at your normalized scales, you can look at difference maps. So you can manipulate it in very similar ways as you can in your topography software. What you then need to do is add in your refractive data. So you click on these plus or minus specs, excuse me, and when you do that, a box appears that you fill in. If you fill in the time here, it's pretty much irrelevant in the initial fit, but it becomes more relevant when we get to follow up because we want to see what sort of time in the day it was to see if there is any regression. Your unaided vision, again, is not really that relevant in this initial fit, but it becomes enormously important when we get to follow up because we want to know what the patient can see without the lenses in. You fill in your sphere, SIL, axis, VA, NIRAD, if you've got one, vertex distance defaults, but if you need to change it, you can do, and then you need to complete your corneal diameter. Most topography softwares will allow you to accurately measure your corneal diameter in the topography software. It's much more accurate than wobbling a ruler around a patient, so use that if you can, but if not, a measurement with a ruler will have to do. And then you click on confirm and you repeat for the left eye. There's a notes tab up there, and it's best actually to ignore that notes tab because anything that you include on that notes tab will only ever be seen by you, and you're probably including those notes elsewhere in your clinical records. Unfortunately, we don't see notes that are dropped in there. Then you can click on this EyeDream tab and you'll see a set of summary data that goes off to the lab. But the raw topography also goes off to the lab. You just don't see that at this stage. And that means that at our end, we can do exactly the same things as you were doing. So we can change between axial and tangential. We can do normalized, absolute, etc. So rather than just sending us a topography file, we've got everything all together in the same place. You then click on send and this box will appear. Now in this remarks box here, where I've written first lenses, please, if you write a note in here, then that will always and forever be associated with that topography at our end at the lab in our support software. So that's the ideal place to put a note. If you put it in the body of the email that you attach this to, they get separated at our end when we get to the order stage, and therefore we don't know anything that you might want to add there. And the things that you could add there would be things that we can't tell from the topography. So maybe you want to tell us about a little bit of staining, or maybe you want to tell us that the patient wasn't as comfortable as they'd hoped, etc. Then you can pop those details in there. At this point, your system will either be set up to mail automatically, and that works if you've got Outlook as your mail service, if as established as an app on your computer. If you use a web-based system, then actually it just makes an attachment. You save that in a folder, and then you attach it as you would do for a normal email attachment. If you do EyeDream Monovision, it's really the same steps, but you choose EyeDream Monovision here. When you get to this screen, you come up to the top right and you tell it which eye you want the add in. I'll just go back so you can see that, which eye you want the add in and how much the add is. And that means that we will know that you're aiming at monovision and we'll undercorrect that eye. So the lenses take about a week to get to you, so you can arrange your collection and teach appointment. When the lenses come to you, the right lens is purple and the left lens is blue. And this is just to give you a really visual way of knowing which is which, because the power will always be plus 0.75 and the base curves, even if you had a radioscope, could actually be exactly the same, but with different peripheral curves, and you're not going to be able to measure that in practice. So by having the right purple and the left blue, you'll always be able to tell the difference between the two. You can pop the lenses in, and at that point you can check that the patient can see well, because that means that your base curve has been calculated correctly. Bearing in mind that these lenses, whilst a little bit more comfortable than a regular corneal GP, are not super comfortable in an open eye, so don't drag this part out. When you put those lenses in, though, the great thing is that if the patient is uncomfortable, you just tell them to close their eyes. And at that point, they feel immediate relief, and you can remind them that that's how they're actually going to wear these lenses. So that's really reassuring for them. You can see that I put fluorescein there with a question mark, and I'll make my argument in a moment as to why you don't need to do fluorescein. You can have a really good long discussion about what to do about overnight wear and if they have any problems. A lot of that is about giving the patient permission to use their common sense. So if your eye feels uncomfortable, take the lens out. If your eye feels okay once you've taken the lens out, give the lens a clean, pop it back in. If it feels okay, go back to sleep. If it doesn't, leave it out and contact us in the morning. So it just means using their common sense and not forcing themselves to wear an uncomfortable lens throughout the night. And we'll talk about binding a little bit in a moment, because that's part of your wear and care teach. As far as the insertion and removal goes, insertion is really just the same as it would be for an RGP, which is straight onto the cornea. And the removal has to usually be the 2 fingers and sort of tiddlywink the lenses out rather than the single finger and blink, just because they're larger lenses and it's harder to get the lids either side of the lens. You're going to talk to them a lot about lens and case hygiene. The first presentation that I ever saw, well, the first conference I ever went to about Ortho-K included a presentation by Professor Pauline Cho, who works in Hong Kong, and she'd done a study looking at contamination of lenses and cases in Hong Kong, and she made the point that most people keep their lenses, keeps their case and solution bottles in the bathroom. And this was really the first time that it had been pointed out to me that this isn't ideal, that those bathrooms are warm and moist and full of bugs. So they're the perfect place to grow bugs on the outsides of cases, outsides of solution bottles. So it doesn't really matter how vigilant you are about washing your hands, you're still then going to handle those. And so she pointed out that it's better to keep your lens case and solution outside of the bathroom, and maybe just use the bathroom for the mirror and the sink. And she also finished the presentation by asking everybody where they keep their toothbrush and pointing out that the toilet aerosol can go 6 feet and land on everything that's around there. So a lot of people at that point were thinking about where they might keep their toothbrush in the future. You're going to make your patient an appointment to come in ideally first thing in the morning the following day, so they can sleep with their lenses that day. When we first started doing Ortho-K, the recommendation was that the patient came into that first follow-up appointment with their lenses in. And that was because you wanted to ensure that the patient could see to come into that appointment. And also you wanted to make sure that nobody was going to try and take out a bound lens. And we will talk about binding a little bit more in a moment. The problem with daytime wear is, as we discussed earlier, which is that you can get lid hitch and movement and blink. And actually your patient might be coming in for that 9 o'clock appointment, but they're likely to have been awake since at least 7. So that's a couple of hours of movement, blink, lid hitch, etc. And therefore it can really blur that first day topography. So our preference these days is that the patient comes in without the lenses in, and that the exceptions to that are an adult that needs to drive themselves in should keep the lenses in because we know they can see in the lenses. And if anyone has difficulty removing them, we'd rather they left them in and came in and we revisited removal at that point than forcing them and causing themselves a problem. So my question mark on fluorescein. When I started in Ortho-K, the majority of systems were fluorescein based, and I went to that conference in Chicago and went through the accreditation systems of a number of different lenses, and it always involved looking at a lot of fluorescein patterns and looking at them and deciding whether it was likely to be successful and what you would change if the fluorescein pattern didn't look as it should do. And so you would get images like the one on the left and one on the right, and what everybody tended to do was fall immediately into the trap of saying that one was flat or steep. And we know that Ortho-K lenses are really best not described in terms of flat and steep, because both of those images that you can see in front of you have elements of them that are too flat and elements of them that are too steep. So the one on the left looks very flat in the center, but it doesn't have very much edge clearance. So then that makes us think that maybe it's steep in the periphery. And the one on the right is maybe not as flat as we would hope it to be in the center, but it's really quite flat in the periphery, particularly at 12 and 6 o'clock. So flat and steep are not great descriptors. So you actually want to be thinking more in terms of what does the lens look like in terms of sag. So is the lens got the correct sag, or is it too high or too low? But even that is really difficult to establish with fluorescein. So fluorescein has a number of issues associated with it. Partly we're looking at it in an open eye, not a closed eye, so it's an unnatural situation to be looking at the lens in, and you can't get around that. The lens tends to be dynamic, so it's not like those still images we just saw. It is moving with blink, and the patient's eyes are watering, and fluorescein might be disappearing really quite quickly. And so therefore we're not going to get an accurate assessment. But really, the thing that really lets us off the hook is that actually we cannot be as accurate enough with fluorescein to get a good fit. We can't see fluorescein until it hits 20 microns, and the thin layers associated with Ortho-K are around 5 to 10 microns. So that's going to look like touch, even though it's clearing. And when you get into the reverse curve, you're at maximum fluorescence. So you're not going to be able to see subtle changes in that either. And this study by John Mountford here in 2003 really demonstrated that experienced ortho-K fitters are no better at checking the correct fluorescein fit than new fitters, because it is just impossible to do so. And so experienced ortho-K fitters are really good at managing patients, but their skills aren't based on their fluorescein assessment. And so this helps back up the idea that empirical systems designed on your patient's topography, rather than systems where a fluorescein fit is essential, generally are more successful. Philip, can I help you with a question? As you've raised your hand. Hello.
Indeed. Is there any advantage to doing anterior OCT to see how your lens fits under?
I would be completely fascinated to see what that looked like, because you should theoretically be able to measure those very thin tear films. But the reason why I wouldn't say that it gives you loads more is because you don't have another lens in a fitting set there to pop in. And it was calculated empirically for your patient. So actually wearing that lens overnight is going to give you the ultimate in what the outcome is going to be. So I think I'd go down the kind of route of thinking that it was really interesting, but maybe it doesn't add a great deal clinically to your decision making. Okay. Does that sound reasonable?
Yeah.
Cool. Excellent. Binding. So binding is a phenomenon of sleeping in a gas permeable lens. So when you sleep in a gas permeable lens, the forces underneath it make that lens stationary, and then it tends to bind. And the binding in itself is not the problem. The problem comes when a patient removes a bound lens, because it takes epithelium off at the same time, and it is incredibly uncomfortable. So most of us will have had that RGP wearer who falls asleep on the sofa, and then when they wake up, they're very used to the idea that they have to give the lens a wriggle to get it moving again. For our ortho-K patients, the best advice that we can give them is to not remove their lenses immediately on waking, and just wait 20 minutes or so, because it's actually going to be likely to get moving just from natural blink movement, and also from tears getting behind the lens. If that's not enough, then they could use some re-wetting drops or comfort drops, or whatever we want to call them these days, to get that lens moving. And if necessary, they can do that nudge with the bottom lid, but they really want to make sure that it's not a nudge that's going to force that lens out. Because if they do it, then they're going to get the appearance similar to this, which is that you've popped a lot of epithelium off. And if a patient comes in having done that, then if you put a thin soft lens over the top, it will act as a bandage. The damage tends to be very shallow, so it re-epithelializes quickly, but the patient can be really put off by the experience, because it's really uncomfortable, because the lid and the atmosphere are hitting that exposed cornea, and then can be really painful. So luckily, I've not had this happen to any of my patients, and I think it's because I talk to them so extensively about binding to make sure that they're not going to try and take it out. They've got to be able to see that lens moving or feel that lens moving before they take it out. If you did have a patient who has binding, it's really tempting to think that it's because the lens doesn't fit properly, but it's actually just a phenomenon of rigid lens wear and sleep. And so you want to change those parameters really as a last resort, because otherwise, if you change parameters, you might have a less successful effect and still have the binding. So don't jump to change that. When you're doing that teach, we have a wear and care guide. We used to make these as printed copies, and everybody, like we do with everything in practice, ran out when they had a patient there. So we made it available to you as a PDF. We do still print a few, and you can ask us for those, but actually the PDF works well for most places, because you can either print it yourself, or you can email it to a patient, or host it on your website and send them a link to that. And it just means that you've always got it available to you. It's got all the do's and don'ts, etc., in patient-friendly terms, and is a useful document. My other hat at number 7 used to be that I led the compliance team, and I became completely obsessed with the IFU, or instructions for use. And that's the little folded piece of paper that slots into our wallet when we send the lenses out to you. And I think the reason I became slightly obsessed by it is that I think until then it had completely escaped me as a practitioner that this was a document that was supposed to go to the patient and not just for me. So if you make sure that you pass that on to the patient, they get everything that they need to go with that lens. I was also surprised to realise that soft lens manufacturers are also supposed to provide these IFUs, and they do that by providing you with pads of them that you rip off and give to the patient. But I wasn't sure I'd ever seen one. Care products. So care products, you want to make this as simple as you possibly can for your patient. So you don't want chemistry sets. So although there are multiple images here, the vast majority of patients will just need a multi-purpose RGP solution to do a rub and rinse with, and then soak and disinfect. And the product that you can see there is the EyeDream solution. It's actually the same as the Ote Fine solution, and it's just been repackaged to go along with EyeDream as a package. It's slightly cheaper than the Ote Fine solution, so that's another good reason to use it. But it is just a simple multi-purpose solution. So you could equally, if you're in practice where you have something like Medicare Plus, Boston Sim Plus, I'm sure there are some more, you're absolutely fine swapping those out. The ones that obviously are slightly less attractive are things like the Delta and the Total Care, because they have a separate cleaner, but those two are both also suitable. The one system that is less suitable is the Boston two-step solution. So not the Sim Plus, but the one with the cleaning and the wetting and soaking. And that's because the cleaner is abrasive. So it's always been described as polymeric beads, but it's basically gritty. And when you clean, it's really super effective at removing things, protein and other deposits, but it's also very effective at changing the shape of the lens by polishing. So in Ortho-K, this would be a problem because you may lose effect of the lenses. So really do avoid that Boston cleaner. It also takes away all the benefits of the plasma treatment that these lenses have as standard. So avoiding that gritty cleaner is really important. If you did need to add in a separate cleaner, you can obviously add in something like the Delta or the Total Care cleaner, or the Ote Clean. Having said that, the Ote Clean is particularly, because it's alcohol-based, it's particularly effective at cleaning lipids. And lipids often bother our patients because of vision. And as the patient isn't likely to be sleeping in these seeing in these lenses because they're sleeping in them, maybe lipid isn't something that's going to bother them particularly. If you have a patient that is a heavy depositor, then you could think about trying to add in a tablet-based protein remover, but you're going to struggle to find one of those these days. So an alternative option might be something like Progent. Progent comes in those two separate vials that you can see there, and you mix them in the case and then leave the lenses in there for half an hour and then go through your normal soaking solution. And it is like magic. You can take a very heavily deposited lens and you'll bring it out looking lovely and sparkly clean. The majority of patients aren't going to need to do that because the lenses are replaced every 6 months. And I tend to only add it in if I get the patient, when they come in for their 3-month check that we do 3 months after they start the process, I look at the lenses off-eye. And if they have that kind of dull, matte appearance that you get with a deposited lens, then that's the point when I would add in the Progent and maybe just use it once a month. But the majority of people don't use it. Re-wetting drops are really useful. If you're going to put them in the morning to get the lens moving, you kind of want something fairly light in consistency, so not something very viscous because you want it to get behind the lens. But the opposite is actually true for something that you put in before sleep, because actually something of high viscosity is going to cushion that lens. And that's why I've got a picture of the Hycosan Extra, because it's a nice thick viscous solution that's actually going to stay there and act as a cushion for that lens. And we'll talk a bit more about why that might be important when we get onto staining. So your aftercare visits, your first aftercare visit is at after the first night, and you're going to see the patient ideally as close to waking as you can. The lenses shouldn't be warm, but with the exceptions that we talked about earlier. Get an idea of how the patient got on. A lot of it is about reassuring them at this stage. Some of them won't sleep very well because they'll be thinking about it. They might be aware of the lenses even if they're not uncomfortable. Do a slit lamp and make sure that you have a relatively low tolerance for staining. A good exercise is to have a look at how much staining patients who don't wear contact lenses have when they first get up in the morning, because some of them will show the odd dot of SPK, and that's the kind of level that we can tolerate in Ortho-K. But anything that is more a distinctive pattern or anything confluent, we should be really not expecting. This isn't a lens type that is likely to be causing us significant problems. And we'll look at some pictures of that towards the end. You're going to do their uncorrected vision, and you're going to do a residual refraction, and you're going to do their topography. At this stage, for the majority of patients, you get about two diopters of reduction in their prescription. So a low myope might be seeing really well straight away, but your higher myopes, they may be aware that their unaided vision has improved, but they're still going to need help to be able to get about their normal everyday life. The best way to do that is actually with some daily disposables. So you could give them a couple of pairs in their residual prescription and a couple of pairs in half their residual prescription, and that will get them through to the next appointment. Talk to them about reflections and fluctuation in their prescription, and remind them always to carry those ortho-K lenses in the early stages, just because it's there as an emergency top-up. So do you need to send us topography every single time you see a patient? Well, the simple answer to that is no, you don't need to. If you feel confident and you feel happy that it looks as it should do, then you can not bother to send that topography, but you can send it to us for reassurance or help for as long as you need to. So if you just want to send us topographies and say in that little remarks box, is this okay? Then we will reply back, hopefully really quickly, just to say, yep, looks good, carry on wearing. If you start to see the same pattern over and over again, you might decide that you don't need to do that anymore, but you can do it for as long as you need to. I stopped sending topographies to number 7 on a day when I answered my own email. So I sent one from practice on a Saturday, and on a Monday morning, I was on the technical help desk and answered the email and nearly replied to myself to say, yes, that looks fine. And that was the point when I realised that I didn't need to do that anymore. But I'd been sending them for a very long time before that. If you're not going to send us the topography, do get into the habit of transferring your topography and your prescription, residual prescription, into the EyeDream software, because it builds up a lovely long history of each appointment, and it's really useful for us to refer back to if we need to change something in the future. So it's a really good habit to get into. Your second aftercare visit is going to be at about 5 to 7 nights, and ideally again in the morning. Again, all the same things as you did before. In terms of refractive change, your low myopes will be well corrected, but your higher myopes might not yet have achieved full correction, and they're going to need some encouragement because the change slows down. You don't get big jumps of 2 diopters after the first night. It's just a gradual change towards full correction. This tends to be the first point that the topography is really clear enough to determine lens position. Sometimes it's super obvious on that first night, but sometimes it's just not that clear. And this tends to be the first point that we change for position. And again, no need to send us the topography if you're confident. So I have a refraction top tip, and this came again from my time in refractive surgery, which is that delighted patients should remain delighted. And if you fiddle around with small residual refractions, which if you're anything like me, you can't stop yourself from doing, getting the cross seals out even when the patient sees well, just don't do that, then you may not be able to recreate that with new lenses. And the patient could therefore be disappointed. So what I tended to do, always in refractive surgery and now in ortho-K, is always finish with a binocular +1. Because if you finish with a binocular +1 and you take that trial frame off, it will always look much better. Whereas if you finish with your residual refraction and remove the trial frame, the patient could be disappointed. So binocular +1 becomes a really good tool just to help the patient leave feeling as happy as they came in. So your third aftercare visit is around 10 to 14 nights. All the research suggests that there's no significant change after 10 nights. So therefore, as long as you do it after 10 nights, you're not going to be wondering whether if you'd left it longer, it would be better. If you do it at 8 nights, you're going to be wondering whether you should actually have left it that bit longer. You're going to be doing all the same things. And at this point, you've got the final result that you're going to get with that pair of lenses. So a good result is the patient's comfortably wearing their lenses overnight, they're happy with their vision, and they get minimal or no staining on slit lamp. If all of that is true, then in some ways you don't need to worry about what the topography is doing. You can actually kind of make an assumption that it is a well-centered treatment zone because you've got the outcome that you want. A lot of ortho-K presentations will talk to you about topography being the key of this, and it absolutely is the key. But the outcome is the really important part. And so the reason that I've left topography till later is actually we're focusing on the outcomes, and then the topography is a tool to get us there. So we will look at topography maps, but we're aiming for that good vision, good comfort, and good slit lamp, and using the topography as a tool to get there. So before we look at those topography maps, and in our last few minutes, I just wanted to give you an idea of safety and complications for 2 reasons. One is because I think it's really important that we look at the safety so that we can advise our patients well. And the second one is because it also gives us an idea of what we might see in these patients when we see them. So rather than just go from experience, I went back to this paper from 2016, which is a systematic review of the safety of orthokeratology. And this paper looked at 170 papers. Not all of those 170 papers looked specifically at safety, but they were all papers that recorded complications within their study groups. And they looked at things from the most serious end, like microbial keratitis, all the way down to the less serious corneal staining, binding, tear film, etc. So the one that's always going to concern us the most is microbial keratitis. And if you go back to when I started in Ortho-K, there was a considerable concern about the risk of Ortho-K, because in the early 2000s, there were reports of a case series of patients who developed microbial keratitis in the very late 90s. And the majority of these were children, and it really made people quite alarmed. But what we should always bear in mind is that this relates to a period where China was a really poorly regulated market for contact lenses and medical devices in general. This is a point where you could pretty much self-fit with Ortho-K, and that tap water was sold in solution bottles for care of these products. China in the early 2000s went from being one of the most poorly regulated markets to being one of the most tightly regulated markets for medical devices and other things. It coincided with the period where there was the baby milk scandal. So I don't know if you remember that, but babies died from contaminated powdered baby milk. And a lot of Chinese families flew to the States and to Europe to pack suitcases with baby milk because they lost all confidence in Chinese baby milk. And this is the point where China increased its regulation hugely. And so now China is actually probably the tightest regulated market in the world. We always think of the FDA and the CE mark as the tightest, but maybe China actually exceeds that. China currently only has European and American Ortho-K products, and you have to be practicing in a hospital, although I hear that's due to change, and you have to have gone through an accreditation system. So again, it's tightly regulated, and it does seem to be that the overall incidence has reduced significantly. So I think we can kind of put that to one side and actually try and look at something that is more relevant to our current practice. The Bullimore paper that we've got here at the bottom was carried out as a response to the requirement of the US FDA to do post-market surveillance of your product. And so Mark Bullimore was commissioned to do this study on behalf of a number of manufacturers that had the overnight indication for Ortho-K. And it was a retrospective study, and he sent out questionnaires to practitioners that had placed orders with these manufacturers and got them to report back on the patients who had those lenses. He received back 1,317 questionnaires to represent those patients, and they worked out how long the patients had been wearing these lenses, and that came to just under 2,600 patient years of wear. Now, you're probably familiar with the rates of microbial keratitis being given per 10,000 years of wear from those large population studies, where they go to a tertiary centre and they look and see what the risk factors for those patients were. And obviously 2,600 is less than that, so they have to extrapolate those figures up to reach the 10,000 years of wear. In those patients, there were 2 cases of microbial keratitis and no loss of best corrected vision. So both patients were treated successfully and maintained their best corrected vision. When you do that extrapolation up, you get a rate of microbial keratitis of overall 7.7 per 10,000 years of wear. And in the paediatric cases, because both cases were in children, it's 13.9 per 10,000 years of wear. But with both of them with very large confidence intervals because of that extrapolation up to 10,000 years of wear. So all of this is good sound data. I think the problem I have is actually when it comes to Mark Bullimore's conclusion in this paper, because he relates those rates back to one of those large population studies. So this was a population study based in Australia, published in 2008. And his comment in his conclusion is that Ortho-K is very similar to other forms of overnight contact lens wear, which would be down at the bottom here. Overnight soft lenses at 19.5 and overnight silicone hydrogels at 25.5 per 10,000. The problem is that the 7.7 and the 13.9 actually just sit either side of this daily wear silicone hydrogel, and they're closer to that than they are to the overnight wear. So I just think that the conclusion he drew is not strictly as accurate as it could be. So I think we should always acknowledge risk in contact lenses. We should acknowledge risk when we fit daily disposables, and we should talk about that risk. And an interesting thing that I do every year I go and teach at the universities is ask the students what the safest way to wear contact lenses is. And daily disposables drops out of their mouth before they can think about it. And they've completely forgotten that gas permeable lens wear is much safer than daily disposable lens wear. So, we do need to think about relative risk, but actually when we're communicating with patients, the thing that is absolutely the most important is about how we decrease that risk. So how we make sure that they are doing good hygiene practices, that they're replacing their lenses properly, that they know what to do if they have a problem. Because although the risk is increased, it's a small increase, it's still very rare, and that we can do things to decrease that risk. One of the things that we can do to decrease that risk is actually to make sure that we keep staining to an absolute minimum. I'm sure some of you are looking at this on small screens and it's going to be really hard on this top picture here, but there are a couple of dots just right at the edge of that beam of staining, and that's the kind of level of staining that actually we see in patients that don't wear lenses. And because these patients are going to be lens free all day, it's very likely that that's going to re-epithelialize during the day, because we know that cell turnover in the epithelium is rapid anyway. The one on the bottom, on the other hand, is something that we really can't tolerate. And the reason we can't tolerate it is because it's in a pattern, so it's got a circular shape to it. It's right smack bang over the pupil. So if we were to get an infection there, that would be the worst case scenario. And you can, if you're able to, on the screen you're looking at, see that the fluorescein is diffusing in that central area, which suggests it's going much deeper than just very shallow. If you were to see staining like this, you definitely can't say to the patient, carry on wearing them. You need to cease wear and let that re-epithelialize. But it's very tempting to think that that must be because the lens is too flat and it's squashing on the central cornea. But what we know is actually this kind of staining is much more common in two circumstances. One is in patients who don't have great tear films. Actually, there are three circumstances. One is patients who don't have great tear films. The second one is in higher prescription changes because the reverse geometry is much more obvious. And the third one is actually patients who put their lenses in out of that lovely conditioning solution and then watch TV or read for ages before they go to sleep because all that lovely solution is washed away. And so it's actually easier to get rid of staining or reduce it or eliminate it with increased use of lubricants than it is actually by lens parameter change. Because in all of those circumstances, increased lubrication is going to help. In your drier-eyed patient, just having something nice and viscous like that Hycosan Extra is going to help. In your high prescription patients with the more extreme reverse geometry, putting it in the bowl of the lens as they go to insert it can help. And patients who read or watch TV can have something by the side of the bed and just blink it, pop it in and then blink it through, and that will help. So that will always be my first point to try and reduce the staining, and really only look at parameter change if you really can't resolve it like that. We talked about binding, and I'm not going to talk about that again. Iron ring deposits can be seen in the reverse curve, and it's thought to be the same kind of processes as you get it in keratoconus, which is that you have an abrupt curvature change. There was concern a few years ago about the endothelium, but that has been is much less of a worry now that good research has shown that there's no significant long or short-term changes. And as far as pressure is concerned, probably the take-home message is that your cornea thins slightly centrally, so the measurement of your IOP is likely to read a couple of 1 to 2 millimeters lower than it would read if you didn't have ortho-K. So that really only is important for patients who are a bit borderline and with other risk factors. I think in the future we're going to be measuring corneal thickness and combining that with our pressure measurements anyway, so maybe that will become less of an issue. So your ongoing appointment schedule is 3 months from your initial fit, 6 months from your initial fit, and 6 monthly ongoing. Lenses are replaced every 6 months. Now, infection. This doesn't have to mean a serious infection. This could mean conjunctivitis. This could mean, these days we should probably think about whether we're advising patients to continue wearing lenses if they get COVID, for example. Ortho-K does present a unique problem, and that is that the patient has a period between correction and baseline, and they can't just go straight back to their old specs. Kids have huge amounts of accommodation, and probably as soon as they notice the vision dropping off, probably could go back to old specs, but you'll have to manage it more carefully with adults. One option is dispensing specs with half their prescription when they're happy with the result of their Ortho-K and they're going to continue. Other practices have specs glazed up with -2s, -3s and maybe -4s and lend those to patients. If you have glazing on site, then obviously it's not so much of a concern for you. But it is something that the patient should know is a possibility for the future. Another cheery thought to nearly finish on is knowing when to give up. So for some patients, either their correction or their centration just can't be achieved. And that is likely to be that they've had 3 lenses and that they just aren't getting the results that you want. If you have 3 lenses and then you achieve centration and you need a bit of extra correction, then maybe we'll go for the 4th one. But generally, that's a decent rule to go with. And it's at that point that it's good to draw a line under it. Don't let it drag on and patient loses confidence, you lose confidence. Just offer them an alternative option. So if it's for myopia management, we're really fortunate that we've got MiSight and Natural View and spec options, and there is likely to be something there for your patient. And for adult patients, we've got all sorts of other products. They might not give them all the benefits of Ortho-K, but hopefully we can find something that works for them. So as promised, a couple of minutes on topography outcomes, very deliberately left till the end. So here's your bullseye pattern. So here is your well-centered flattened zone with your mid-peripheral ring, and that's your ideal pattern. And hopefully all the patients you see will see this. But decentration is your enemy, because decentration introduces multiple powers across that pupil, and therefore you're going to get the distortions and aberrations associated with that and the drop in vision. This is a smiley face pattern. It's high riding and you get the smile underneath it. And this is a result of the lens not having enough sag or sagittal depth. To change the sag in an Ortho-K lens, you only change peripheral curves. Your base curve is just there for prescription change. And to increase sagittal depth, you need to steepen your peripheral curves to lift that lens up. You can see here we've given you an indication of how much you might change those, but actually within these empirical systems, you send us the topography, we make those amendments at our end. So the alternative is a frowny face pattern. So this is a low riding lens and you get the frown over the top, and this is where you have excessive sagittal depth, so therefore you're going to decrease it by flattening your peripheral curves. And again, we make those decisions on how much at our end. Lateral decentration can be a little bit more challenging to deal with, because sometimes it's down to the patient, rather than needing a lens fit change, it's actually down to the patient's geometry. So their cornea may actually be just slightly tilted or have different eccentricity nasally and temporally, and that's often because of the way that the muscles are inserted. And really often the only way to deal with this is to go for a larger lens. If you can't get a larger lens because you're already at the largest lens, then we will make some changes, and it's maybe that we go in one direction and that doesn't work, so we go in the other direction to see if that works. But they can be more challenging, and as I said earlier, sometimes they're down to the fact the patient is actually manually decentering them unconsciously. Central islands are the prettiest pattern that we tend to see, and this is worth bearing in mind that this is a difference map. So that red bit in the middle is not that the cornea has not yet flattened, it's actually that the cornea has become steeper in that zone. Sometimes these patients see well on a high contrast chart, but tell you that the vision's rubbish, and sometimes the refraction goes all over the place because you've got cornea that is both steep and flat, and your topography explains that once you've done that. Here, again, we decrease the sag by making those changes to the peripheral curves. Oh, before I finish off, I just wanted to say a couple of things actually about these maps. If you have a decentered lens, then you can't let the patient carry on wearing that lens and wait till the new one comes and put the new one in, because it will just sit where the old lens sat. So you do need to get them to wash out and make sure that they've got a relatively normal cornea, so the time that it takes for the new lens to come to you, and then put the new lens in. Otherwise, it will just sit in that same old position. So to finish off, my tips are: be selective, choose patients well and stay within the selected recommended parameters. Let your pajama folders deselect themselves. You know who they are, but they also probably know who they are. the open door policy here relates to the fact that some of the questions your support team might get asked, or some of the things the patients want to ask, will be things that nobody's familiar with. So therefore, you might need to be a bit more available than maybe you would be for your average patient. And then nag about rub and rinse and hygiene, and really make sure that they know what to do if they do have a problem. But most importantly, enjoy fitting ortho-K. It's really rewarding. It's really fun. The patients honestly think that it's magical and think it's the most exciting thing ever. And that will always cheer me up in the middle of the day. When you go to do the last test, the password for that, there's a question in there that is just to ensure that you come to the webinar. And that's just asking you to fill in that EyeDream -9556091, randomly selected. In the morning, I will email everybody to let them know that that's the password and a few other bits and pieces of resources. So if you want to do the test tonight, make a quick note of that, but otherwise you'll get that in my email tomorrow. I'll also hopefully be able to link you to the recording, but if that's not tomorrow, that will be early next week. Does anybody have any questions?
Hello.
Hello.
Costs, charges, etc., etc.
Yes. So the costs. There's a patient pricing bit of information in the folder that I'm going to send you. But I'm just now trying to find the pricing. We have two different pricing options. One is our ortho-Care plan. And that is a monthly payment that you pay us. So you pay us an initial fee for your patients, and just getting this price list up here. I tend to pretend I'm somewhat like the Queen and don't deal with money, but that's slightly ridiculous. So pricing, let me just see. I'll get myself to the right page and then I'll share this page with you. So let's stop sharing that one and find an alternative one to share. So, right, so here, hopefully you can see this. Your initial fit per lens on our EyeDream plan is $24.29. So you double that and that's your initial fit fee. And that covers you for your initial lenses and any replacements that you need in that initial trial period to get the correct fit. And then you pay $17.16 per pair, so not per eye, per pair, every month. This is to align it with the fact that you can then set up a monthly charge to your patient, and you will continue to get replacement lenses every 6 months. It also covers you for two lost or broken lenses during the year. So that could be a pair that the patient mislays, but most of the time they lose or break one at a time. So you can do that at 2 separate times during the year. And that's then a payment that's ongoing. If the patient needs a toric, the initial fit is slightly more expensive, but the monthly fee stays the same. The alternative is that you go on the pay-as-you-go, and this is just a regular lens purchase. So it's $64.60 per lens for the standard, $77.28 for the toric, and you just order these as you need them every 6 months, and they just come with our regular returns facility. The majority of patient practices go onto this EyeDream care plan so that they can set up a monthly scheme that aligns with it. Does that answer your question?
Yeah. Do you know what? I haven't investigated what other people charge for that. Do you know what a typical
Do you mean in terms of patient to the way that we tend to, because setting recommended pricing is something that has fought with all sorts of problems, but what we tend to say is that the majority of practices tend to charge the same for it as they do for a quality daily disposable worn every day. So a monthly fee of around sort of 40, 45, depending on what your fee structure is like. And the initial fit we tend to recommend is somewhere between £150 and £200, and that's just to cover your chair costs. The initial fit fee for the EyeDream care plan is non-refundable, and we would suggest that you keep at least some element of that the same in your initial fit fee for the practice to cover that chair time. In practice, we tend successful, so we tended to give them a £50 credit if it was unsuccessful, so they didn't take cash out of the till, but they could use that towards another type of contact lens or you know, spectacles or something. So that seemed to work and work for the patients as well.
Thank you.
Lovely. Thanks ever so much, and I'm glad that we kind of finished on time. I've got my first ever in-person Spanish lesson in a bit, so I'll be heading off to that in a moment. So real people and everything. Thanks ever so much for your time. I hope you all have a really good evening, and you'll get that email from me. If you have any questions that occur to you after we finish, then let me know.
Buenas noches.
Indeed. Hopefully I'll know what that means later.
Thank you so much.
Thank you. Take care.